39 on the other. So it's a portal system specifically with the liver. So system of veins, so that carries nutrient-rich blood from the digestive organs. I'll show you in this next slide so you get a good visual. So stomach, small intestine, spleen, pancreas, directly to the liver before it returns to the heart. So this first pass delivery allows the liver to process, store, and detoxify nutrients, drugs, and toxins absorbed from the gut before they enter general circulation. So, portal vein basically is going to receive from the superior mesenteric, splenic vein, and gastric veins. Here's a visual for you. Kind of runs how that goes from the small intestine, goes up there, hepatic portal. The liver's going to do what it needs to do, take care of the body, get all its toxins out, and then it's going to go by way of hepatic veins, which empty into the inferior vena cava, and eventually into the heart. Just review, I'm not going to test you on pathophys, I'm not going to test you on anatomy. You need to understand concepts of how things appear, how they present, how do you evaluate them, how do you treat them, and disposition. So we're going to focus more on that. This is just a quick slide. It goes splenic vein, superior mesenteric into the hepatic portal vein. Hepatic veins up the inferior vena cava. And then, of course, the liver needs blood to run on its own, not just filter the venous blood. So the abdominal liver is going to come back to the hepatic artery and supply the liver with what it needs. And what two substrates do most organs run off of? Oxygen, and then it needs some form of glucose, right? Similar to the brain. When substrates aren't there, bad things happen. Bad things happen. Another, just a nice picture there so you can see the biggest scene. The two tributaries from the mesenteric veins, superior mesenteric and inferior mesenteric, and then we have the splenic vein. So that all comes in to form the portal vein, form into the portal vein. So what are we concerned about with this is when this area gets hypertension. Pressures get too high. That is from, there's resistance to the portal blood flow. So that is usually due to increased portal collateral blood flow. And we deal with this a lot of times with cirrhosis when you have significant scarring in there. Now, your book answer is we consider increase in portal pressure greater than 10 millimeters of mercury is what's going to be considered the gold standard for what is considered hypertension. So the short version, cirrhosis causes that increased intrahepatic vascular resistance, and then the increased capillary pressure, increased hepatic lymph formation, and then we ultimately end up developing ascites. So we need to know a little bit about these levels. So they come in, they can test this. That's a hepatic venous pressure gradient. They go in there and they measure that. So normal is between 1 and 5. Anything greater than 6, anything greater than 6 is concerning subclinical portal hypertension. Subclinical. So 6 to 10, like we would say, let's just call it pre-hypertension. When somebody's there. Once we get over that 10 mark, we're like, yep, we have definite portal hypertension. And we need to start looking at the things we can do. And you see right there, when we get above 12, we're going to start seeing evidence with variceal bleeds and ascites. So one or the other, they don't have to be happening at the same time, but those are two of the complications that we deal with. So similar to bilirubin, when we talked about this, we do have prehepatic. So this is some people that typically have congenital abnormalities. It's blockage of the portal vein before it gets to the liver, So neonatal sepsis can also be an issue with that. Then we have the intrahepatic schistosomiasis. Anybody know what that is? And don't just say parasites, obviously. Okay. So yeah, so we got these blood flukes that infect the human that gets in through usually contaminated fresh water. And then obviously cirrhosis and veno-occlusive disease, that can happen anywhere in the body. and we call it usually a venous thrombosis. That can happen most commonly. We have it happen in the legs with deep vein thrombosis. We have pulmonary embolisms, but this can happen. You can have an infarction anywhere in the body. So, and then we talk about post-hepatic, so outside the liver. So Budd-Chiari we'll talk about a little bit more, but that is usually a rare disorder where veins, liver are narrowed or blocked, preventing blood from flowing out properly. And constrictive pericarditis is just going to cause that to back up inside of the heart, down the inferior vena cava, and ultimately back to the portal vein. It's pretty visual, folks. What are we concerned about this? Because look right there, the esophagus is connected to the portal venous system through a network of veins. Unfortunately, these can form collaterals when that portal pressure is high. So this causes eventually veins in the lower esophagus to enlarge, become fragile, in a condition called esophageal varices. So just see the proximity to that, just so you have an idea how those two interact. People like, how does the liver interact with the esophagus right there? All that blood flow, venous blood flow is backed up. Right here, just for your visual folks, we can see that just breaks down that prehepatic, that intrahepatic, and that post. But what that arrow there is showing is that cirrhosis is most likely cause of this. Cirrhosis, most likely cause of portal hypertension. And what is ascites end up looking like? Pretty bad. Again, I always ask these folks, or I ask somebody's spouse, hey, on a scale of 1 to 10, how bad is it today? People are going to fluctuate, and you'd be surprised how much fluid you can take off of these folks. Pretty incredible, pretty incredible. So this all happens in the peritoneum, the largest serous membrane in the body. So you have simple squamous epithelium and a underlying layer of connective tissue. So divided into two different things. You have the parietal, visceral. This has a lot to do with where people have pain in their abdomen. They describe that there's something called parietal pain, there's something called visceral pain. It has a lot to do with how these are innervated. So you have the wall of the abdominal pelvic cavity being parietal, and then visceral usually covers some of the organs. And then we have the peritoneal cavities, that space between that two layers. Most maintain some form of lubrication so they don't stick together. So small amount of fluid though, very small amount. So if you're getting large amounts of fluid, it's going to get interesting. You have an idea right there. You can see the parietal and visceral peritoneum right there, and then also the peritoneal cavity. And just to give you a visual, looking at that from a lateral view, and looking at that different view right there, just to give you an idea of how this stuff happens. Now a little bit different based on gender, right there. Men typically have very small amount to know, whereas women usually running around with about 20 mLs. 20 mLs of peritoneal cavity fluid. That is normal levels. Anything more than that is concerning. So common causes of that, right here. Yes, hepatic congestion. So congestive heart failure, again, that can back up all the way inferior vena cava back down to the hepatic portal. But right there, liver disease is going to be number one, and specifically cirrhosis. Look up anywhere in the book. Make sure Pan's question here was the most common cause of ascites dealing with portal hypertension. Your answer should be cirrhosis. Should be cirrhosis. And then we have concerns of hypoalbuminuria. So nephrotic syndrome, collection of symptoms due to kidney damage for whatever reason. There's many causes that can happen with that, but basically protein in their urine, low albumin levels, high blood lipids, and significant swelling. So this can be a lot of different complications and infections with that. And you have something called chylus. That's a condition that is essentially been trauma that has been done to the lymphatic system. Trauma, some way, shape, or form, done to the lymphatic system is going to cause that. And you have obviously your pancreatic bile, ascites, as well as infections and malignancies that can cause this as well. But again, cirrhosis, number one. How does this show up? They say they're bloated. Increasing abdominal girth. plus or minus pain, based upon the distension and what the cause is. So, but you want to make sure that you ask some people, do you have any history of liver disease or risk factors for liver disease? Keep in mind that most people are not going to be honest with you about their amount of alcohol intake. What I hear earlier, in dog beers, I've only had one. Maybe they don't crack a joke about it and just go, yeah, okay, fine, 7. Sure. Risk factors for hepatitis, and then history of malignancy. We want to ask these questions. So, good physical exam. There's a reason why we actually check these. Yes, we're going to look for hepatic enlargement. You can percuss that. Check for tenderness. Elevated JVP. So we see that with ascites related to portal hypertension, that's cirrhosis. So that has a lot to do. What else do we see elevated JVP with? CHF, congestive heart failure. All that stuff's backing up. We're backing up the liver, we're backing up in the heart. So large abdominal wall veins. So signs of liver disease, concerning usually with alcoholics, that's going to be muscle wasting, malnourishment. But if we have fever involved in this, we do need to be concerned that we're going into bacterial peritonitis. We examine the belly. We're going to have an idea. We're going to have that transition point. That transition point is where the ascites is sitting below that, and you're going to have more dullness if you were to percuss that, versus more of a tympany when you're above that level of fluid. When you're above that level of fluid. Obviously, you're not having the person laying down here. We're going to elevate the bed, or this doesn't work very well. It does not work very well. So now what do we need to do? Lab testing. So a paracentesis. We're going to stick a needle in there and we're going to drain that. Stick a needle in there, we're going to drain that. We're going to make an initial guess based on how that fluid looks. And you'd be surprised, they can take liters upon liters off of people. I want to have an idea of that, but we mostly want to get this figured out. So clear yellow is normal. So if it's cloudy, we're concerned that there's some infection, then we need to be concerned about a spontaneous bacterial peritonitis. Milky looking is sacchylus, so lymphatic fluid, and then bloody. We worry, is that a trauma or is that a malignancy? So we're going to get an idea of that, and then we're obviously going to send that stuff down. So white cell count, albumin and total protein culture and gram stain. You're not going to get some of that stuff back very soon. You should get the white cell count back pretty quick and have an idea of that underlying infection. So we're going to be careful when we do this that we don't do it traumatic and that affects some of the blood. Same way we do a spinal tap. So this is a very similar thing that once we do this, we don't want to do it again. So if you do a spinal tap, you do one of these get carried down to the lab. They don't get tubed down to the lab. Because if they get lost in any way, shape, or form, you do not want to have to repeat this on somebody, nor would they probably let you after that traumatic experience. Like, yeah, you're not going to do that again. So how does that look? Right there. Now you're thinking we're not doing diagnostic peritoneal lavage, which is how they used to find blood in the abdomen back in the day. We just stick needles in and pull back and see. We don't do that anymore. So this is going to be done under ultrasound. Under ultrasound, we need to find that fluid pocket. There's a special way that we're going to take this fluid off of there, but we're going to drain potentially quite a bit. Quite a bit. So I better have like a lot of those 50 cc syringes laying around because we need to get that fluid off of them. So, and then another thing that we can check right here, you can put this, when I tell you, everybody familiar with what MD Calc is? So it's a website that you can pretty much pull up any type of evaluation tool. So all you got to do is plug in the numbers and it's going to spit you out an answer. So you can just go in there and put in serum albumin and ascitic fluid albumin, put those numbers in, usually anywhere from like 5.5. If it's greater than 1.1, meaning there's increased pressure in that in the venous system, which is indicative of portal hypertension, it's going to have a higher albumin level naturally. So the higher that is above 1.1, we say portal hypertension less than 1.1. This is just two numbers you're going to calculate. It's going to say likely. Usually gives you like a percentage. So I'll tell you, if you're around 2, you're probably like 97% sure that's hypertension. So get that figured out as well to have an idea that yes, that's portal hypertension. We don't need to be concerned about other causes. But we also want to get that imaging. I told you right now that abdominal ultrasound usually is done POCUS, meaning at the bedside, because we're going to look for that fluid pocket, and that's where we're going to aspirate, do that paracentesis. So ultrasound first, and then I'm going to tell you right now, because this person's probably going into the hospital to figure out what's going on, why do they have ascites. You're working them up as much as possible, but they're going to want an abdominal CT to see if there's any other incidental findings, any other diagnosis that they need to make. I mean, is it possible they're alcoholic and now this is also malignancy? Yeah, you're going to have two things running together. You just get locked in, it's like, oh, it can only be this one thing. Definitely be several. So, and how do we usually admit this person? What do they need to get? Who's familiar with the TIPS procedure? The transjugular intrahepatic portosystem shunt. Try and say that 10 times fast. I can't do it. So they put this metal stent in between the branch of the hepatic vein and the portal vein over a catheter via the internal jugular. So obviously very invasive procedure. So, but this is when they confirm that that portal hypertension is what's going on. So this is after post-ultrasound, this is post-SAG level, this is probably post-CT scan, and like, okay, we figured it out, and this is how we're going to attack it, because there's a bunch of different things that ascites can cause. Just for you visual folks, so that basically diverts the portal flow into the hepatic vein. So it's just going to reduce the pressure gradient between the portal and systemic circulations. So I'm going to put that in. This is kind of a last ditch effort to get that taken care of. Everybody clear on this? Warm and fuzzy, maybe? Maybe when you read it, what? I think my test is after Thanksgiving at least. I owe people some clinical inquiry. I will have it done before then. All right. I was wondering, like, this is a weird slide, but this is just a precursor to get into spontaneous bacterial peritonitis. But I think imagery, I get it. I get it. So infection of this fluid that we're calling ascites in the absence of intra-abdominal source of infection. So if it's an intra-abdominal source of infection and it's not due to the ascites, then we would call that secondary bacterial peritonitis. So typically due to a result of chronic liver disease. So anytime that we get stasis in the body, things are not moving along, we run the risk of a bacterial infection taking over. That bacteria has a chance to sit, not getting attacked by white blood cells, and as long as they can get to a source of sugar, glucose, it's probably going to survive pretty well. So unfortunately, poor prognosis. Probably 1 in 3. 1 in 3 are going to pass from this. There's your common pathogens. Common pathogens, number 1 being E. coli, which pretty much is what lives in the GI tract. But you can have Klebsiella. What do we see Klebsiella in? What patient population? Alcoholics. There we go. So it kind of makes sense. It's kind of run together. So strep, gradients, and enterococcus. So, how do we know that things are going this way? They can be subtle and non-specific, but they're going to come in with ascites. Again, fever should be what tips you off that you need to go another way. This is just a normal ascites. So abdominal pain, usually without tenderness palpation. If we are having some tenderness palpation, we need to think that maybe this is not a peritonitis. People can have ascites and fever for a number of different things, but I want to make sure we don't miss that. So again, paracentesis is how we handle this. The gram stain culture, cell count differential for doing that, that gets carried down to the lab. And again, if we think that it's secondary, we may need to get that CT. I'm going to tell you right now, your inpatient team is probably going to want you to get the CT, wherever you may be working. Or if you're inpatient, you're going to want the CT because you want to see if there's any other complications. What are we looking for? Some secondary cause of that, specifically like an abscess, or is this something that's just stemming from a cholangitis or appendicitis or any number of issues. This does not go home, folks. This does not go home. If you have this presenting, you start broad spectrum antibiotics. So usually right there, ceftriaxone, broad spectrum antibiotics. We need to grab big guns, and then we kind of wait. Usually, if this is something that's coming in, you saw it in your TMC, send it to the ER, and then before it gets admitted, we always do cultures and gram stains so that we can treat those medications. Because what's going to come out on a culture in gram stain? Going to tell you what the bacteria is. If we remember back a while, they take that, they grow it into a petri dish, and they're going to put different antibiotics on it. And they're going to figure out, A, is it susceptible versus resistant? We don't want to use those. And then we're probably going to go with something that has the smallest mite, right? That means the less amount of antibiotic it takes to kill the bug. So prophylaxis, so right there, once daily Cipro. These are people that have had it before, okay? So we don't want them to have recurrence. All right. Let's see here. So disease of the liver, so we got miscellaneous as well as carcinomas. So when we say miscellaneous, here's the order that we're going to go into. I know we already touched on hemochromatosis, but we're going to touch on it again. So we've got your cholangitis, that's again an infection typically in all of the biliary tree. That's pretty sad. Talked about Wilson's disease. I talked about Vecchiori a little bit, but we'll go a little more in depth. We're going to talk a little bit about benign and then get into hepatic carcinoma. So primary. So autoimmune destruction right here. Small intrahepatic. There's a reason that's underlined. It's intrahepatic, meaning it's inside the liver, not outside the liver. So solely intrahepatic with the bile ducts. So T lymphocyte mediated. That's why it's autoimmune attack on bile ducts. So destruction of those bile ducts, their cells causes loss of those ducts, which causes cholecystasis. We don't. Stasis means bad. That means open the door for infection. And then cirrhosis and hepatic failure, ultimately. Not good. Here's a picture for you. What I want you to pay attention to is that it gets inflamed, it causes scar tissue, but it is the bile ducts, it is intrahepatic. Versus this, so insidious onset. This is a female gender disease, unfortunately. Majority of those women, 95 years old. Think about that when your patients are coming in, what's common in this population. Usually, I guess you would say middle-aged, so we would say 40 to 50. You're going to see this running with other autoimmune diseases. So Sjogren's. So what happens with Sjogren's? Dry mouth and dry. Yep, autoimmune. They don't produce the saliva, the tears that they need. That must be just horrible. And then autoimmune thyroid disease, typically known as Hashimoto's. And there's a couple other little breakoffs of that. And then we have Raynaud's syndrome, and that is small arteries and fingers and toes spasm due to cold distress. Anybody see anybody with Raynaud's? They will turn ghost white. No fun. Anybody know what you treat it with? That warm gloves? Yeah, sure. Hand warmers? Sure. Toss some channel blocker around.
Viagra.
Just gonna get your hands warm, I guess that's the way to do it. Softball, thank you. Scleroderma. So overproduction of collagen leading to hardening of tight skin, joints, and internal organs. You know how much I had to clean up my comments coming from the amputated medical? People say, your HR file must be this big. No, watch it. So, primary biliary cholangitis. So, incidental finding, abnormal LFTs typically show up, asymptomatic, enlarging of the liver. So, fatigue, usually a first symptom. That's just like, I don't like that when people come to me. I just feel tired. I'm like, what does that mean? That could be anything. You get enough sleep to primary biliary cholangitis. So, pruritus is what we're going to see with these folks. So, and then what's called exanthemus lesions of the skin, and I'll show you a picture of that in a second here. That's just where they have too much cholesterol and fats and now starting to accumulate on the outside of their skin. So that can also have jaundice, fatty liver, and then portal hypertension later. So here's how that looks. These typically will present on the hands. They will get these little cholesterol buildups, fat buildup around the eyes, and then you see it kind of on the extensor surfaces of the elbows. How does that look as far as labs? Okay, cholestatic pattern on a hepatic panel. So liver function test, yeah, we see increased NOC/FOS, we see an increase in bilirubin. May see an elevation of transaminitis, increase in lipids, and then we can get some specific serum markers. So a lot of times this doesn't get figured out until people go to see like a rheumatologist, that kind of thing. Those more deal with autoimmune. We're going to see an AMA, so that's an anti-mitochondrial antibodies present about 95%, and then we can also have ANA antibodies. So this is typically, they will say, I want to get an autoimmune panel. Might be a little bit different in everybody's MTF based on your phase 2. Just be aware of that. You may just have to type these in. So how do we treat that? So first of all, we need to make sure it's not something bad. We make sure it's not a cancer. Make sure it's not a cholangitis, because that can be potentially treated different. And what I'm getting at is as far as a huge infection versus just a primary biliary cholangitis, which we're going to reach for that medicine right there, ursodeoxycholic acid. So it's FDA approved to treat this, slows the progression of the disease, and then we need to put these people on bile salt sequesters. I'm not going to ask anybody specific questions on what that medication is, just know that that helps out with pruritus. So unfortunately, this progresses to liver transplantation, referral to hepatology, or you at least probably have a GI doctor that has done some sort of hepatology fellowship that is your guy to talk to. So, primary biliary cholangitis, what I say, I said that's intrahepatic, that's where that occurs. Well, I want you to pay attention that this one is going to be intra and extrahepatic. So inflammation, fibrosis, and stricturing of the intra and extrahepatic bile ducts. So diffuse inflammation of the biliary tract. So this is a little bit different. We talked about women being the majority of the issue before. Now this is males. So 2 to 1. And onset age 30 to 40. So know your demographics with these folks. And unfortunately, yes, it does have some pretty significant associations with inflammatory bowel disease. Specifically, 90% that have PSC, primary sclerosing cholangitis, also have ulcerative colitis. As smoking decreases the risk. I feel like this is like the 3rd time I'm telling you, like, smoking may be good for you. I would say I'd rather not have this disease. And cigarettes are expensive anyway. Here's your visual. So we see, pay attention to that, so that's extrahepatic and intrahepatic. Extrahepatic and intrahepatic. So, incidental finding, again, abnormal LFT should tip you off to this. Typically, enlargement of the liver, but no symptoms with that. Again, we're going to see pruritus as well as fatigue. There's non-specific symptoms very early. So again, jaundice, enlargement of the liver, enlargement of the spleen, but excoriations, what is that? That just goes right along with that pruritus. Pruritus, itching the skin. These people are clawing at their skin so much that it's leaving marks. Taking that top layer of epidermis off, that is what excoriations look like. It's real sick. Somebody's just been like clawing at themselves. Laboratory findings increase, very similar. The last one, increased NOC/FOS, increase in bilirubin. May see a slight elevation in your AST, ALT. So and then we have a little bit different antibodies for the anti-nuclear, anti-smooth muscle, anti-cardiolipin, but that's going to be your atypical perinuclear anti-neutrophil cytoplasmic antibodies, or your P-A and C8. That's going to be running with more of the PSC versus the biliary. It's going to be more ANA, AMA. So how do we treat that? So we need to first rule that out. So there's something called an MRCP, not to be confused with an ERCP. ERCPs are going to remove a stone, particularly diagnostic and therapeutic. An MRCP is just a MRI where they're going to look at how well the gallbladder is squeezing out bile. Essentially the ejection fraction of the gallbladder. Okay? That's all they're doing with that, and they're going to make a decision, is this a sick gallbladder or not? So what can we do to reverse that process? What can we do to manage the progressive disease? So a combination of immunosuppressive as well as anti-inflammatory agents. I'm not going to get into the nitty-gritty of what any of those have to be, but likely these people will have a liver transplant in their future. Go to hepatology. So, again, if we're putting somebody on immunosuppressive, we're going to run the risk that they're going to get an infection elsewhere. Good visual for you, like I said. Inter and extrahepatic is going to be your PSC versus your PBC is going to be intrahepatic ducts only. Either way, they both are going to progress to cirrhosis and likely going to need liver transplant in the future. So, no fun. We talked about hemochromatosis already. So again, increased iron absorption. This is a genetic disease, so it's typically found by parents. So if you ask, that's why we ask about family history. Mother or father had hemochromatosis, high chance that kiddo can have that as well. So accumulates iron in its own form, and it's broken down in both the liver, pancreas, heart, just all over in a lot of the major organs. So that's just that intercellular iron storage complex that collects all that iron. So unfortunately, yes, it can lead to cirrhosis and or hepatic failure. If they're a drinker, they're just making it even worse, When do we see this? So usually not until the age of 50. Very widespread, vague, if you will, complaints with fatigue, malaise, arthralgias, decreased libido, increased hepatic. So, and then we have all these cardiac symptoms because we're just having too much iron. It's depositing in the heart, so we can have cardiomyopathies, diastolic dysfunction, heart failure, and then unfortunately can cause arrhythmias as well, because that iron is supposed to be there. If you look at these people, bronzing the skin, so I imagine if you think about that, they look like a bodybuilder, but they have hemochromatosis. Neurologic abnormalities is how this can present as well. So pretty sneaky type thing, and not a lot of things going forward with them as far as treatment. So diagnosis made usually before symptoms start showing up. So you see AST, ALT, elevated plasma irons, as well as serum ferritin. So that HFE is just the acronym for the hemochromatosis gene. So they can actually test for that to see if that was passed down. They're going to check family history, but they can actually do genetic testing for that. Prognosis is good when they catch it earlier. Here's the things that they treatment includes. So they need to stay away from things that are hepatic toxic, usually alcohol, and any medication that may cause that. We talked about, these people come in, they actually have to take blood from them. They will take a certain amount of vials, have them hang out for a little bit so they don't go syncopized in their car. There can be chelation therapy with deferoxamine. That's an antidote for iron overdose, and then liver transplant, unfortunately, for these folks as well. And this is a wonky one. I guarantee you there may be one question on your pants that's going to ask you this. So autosomal recessive disorder, usually under the age of 40. So 30 per million people doesn't sound like a lot of people have that, but when we are documented at over, I think, 330 million in the United States, this potentially you can see this. So this is a wonky thing where they actually have excessive absorption of copper. So, and it does not get decreased in the liver. So deposits happen usually in the cornea, the liver, and the brain, which means that's where they're probably going to present the symptoms. If we don't treat it, it can be fatal. So how do we see that? 3 different areas. So liver disease can affect the liver, neurologic symptoms, specifically in the brain. It's going to affect movement, migraines, insomnia, and then psychiatric disorder underlying. What's the biggest symptom that or the biggest sign that we're going to see on our physical exam? Physical exam findings, right here. Kaiser-Fleischer rings. Kaiser-Fleischer. So brownish or greenish ring at the corneoscleral junction. Everybody see that? Okay. That's just where it's depositing in the cornea. It's depositing in the cornea. Diagnostic testing wise, let's get a CBC, CMP, serum copper. I'm going to tell you right now, very important is going to be that serum ceruloplasmin. That's going to be your dead giveaway. That's going to be your dead giveaway. So we should see increase in urinary excretion of copper with a 24-hour UA. So, and then they can do a liver biopsy to see the concentration within the liver. So, chelation of copper is how they take care of that. So referral to GI hepatology. Here, if you like this type of slide, where it's visually presented, that just breaks down, again, that serum level is what's going to drive that. That's your first decision point to send you down the algorithm route. So one is greater than 20, one is under 20. Then we see if they have the rings in their eyes, the Kaiser-Fleischer rings, and then from there we make our decision with what we're going to treat this person with. It's a great movie, great movie. Hence Wilson disease, okay, I guess the movie added too. Probably not, that's a bad joke. But yeah, so hepatic venous outflow tract obstruction. So results in, this is our post-hepatic, so predominantly venous process. Now that can be a thrombosis or that can be a phlebitis. So thrombosis means that we're actually having clot forming there. Phlebitis is more of an inflammation picture, more of an inflammation infection picture. So, and then you can have secondary that has a lot to do with compression from hepatic veins or inferior vena cava. This is usually related to a space-occupying lesion, aka a malignancy. So these people have tender, painful, enlarging liver. They can have jaundice, enlarging spleen, and ascites. So radiologic study choice for this is going to be a colored Doppler ultrasound, usually done by a ultrasound tech in the radiology department, because they need to look for specific things. And how does that actually look in real life? No bueno, no bueno. So ultimately, they need to figure out, why is this person having that ascites? What can they do to fix it? So this patient does not go home. They come in with Budd-Chiari syndrome. They get admitted. This is inpatient after that, not outpatient. Questions on that stuff? We only have a few more slides to go. Talk neoplasms. So, when I say neoplasms, does that mean cancer? No, it doesn't. So here's our first one. Incidental finding. You get an MRI, you get a CT of somebody, they can come back with this cavernous hemangioma. This is nothing to be concerned about. Hemangioma, non-cancerous, benign growth, usually extra blood cells. It can be in the skin, it can be internal organs, other parts of the body. But most commonly where we're going to see that is the liver. You can see that right there on that CT scan of the liver. So nothing to be concerned about. Incidental finding. You want to, you can ultrasound it, sure, it's going to be just fine. People can have these in their spine too. They're going to be just fine. Usually don't need anything as long as they don't fracture. So here's where we get into the nasty stuff. So hepatocellular carcinoma. Number one, look at that, 80% of the cases, cirrhosis, 80% of the cases. That, I'll tell you right now, it's a pants question, but then we have all these other things. We have our Hep B or Hep C, we have our non-alcohol fatty liver disease. Obviously, if you have tobacco, or you're using too much tobacco or alcohol, you run the risk of carcinoma. Diabetes, obesity, yes, hemochromatosis and Wilson's disease, and then we talked about the two flavors of cholangitis are all risk factors for carcinoma. So, mostly due to underlying liver disease. So, we need to be worried about these types of risk factors. So, that's why we ask these questions. You have fever, chills, weight loss, especially at night. Maybe those people don't pay attention to that. So I told you to go back, look at their vitals. They're going to have weights in there. You'll be like, man, you've lost 50 pounds in like 3 months. Should be concerning to you, should be concerning. And then we just say B symptoms, that's hepatitis B symptoms. Flu-like symptoms, so fatigue, joint aches, loss of appetite, nausea, vomiting, abdominal pain, jaundice, you can run with that. And then bone pain from metastasis. That means it has spread from the liver into bone. That's not good, not metastasized. So you see leukocytosis, so increased white count above 12,000, and then elevation of alpha phos, and then we can get a tumor marker, alpha fetoprotein. So that is a huge tumor marker, not just for hepatocellular carcinoma. It can also a huge tumor marker for testicular cancer, believe it or not. So right upper quadrant is what we're going to get first, so a ruckus, and then CT to, if they confirm that there is a lesion, based on that, we need to look further and see if there's any metastasis. And then I'm going to move on to biopsy. How's that going to look? Right there. That big schmutz, that's not good. That's not a hemangioma. That is a hepatocellular carcinoma. And those do not get very good. We have to go in there, and they are going to resection that, where they have to remove the entire liver, and hopefully they are a candidate for a transplant. Pretty horrible prognosis. So pretty horrible prognosis. Survival rate at 1 year, 23%, 5 years, 5%. That's pretty crappy. That's a tough pill to swallow. So, how do we screen for those people? They need to know, hey, have you had a history of cirrhosis? Have you had a history of B or C hepatitis? And then the family history of that. These are risk factors. Very concerning. If they do have any of that that's concerning, we are going to get an ultrasound on them and draw an alpha fetoprotein every 6 months. Every 6 months. Basically until we hopefully can get on top of that first. Questions on all that awesome liver stuff? What are you thinking, folks? I think echo, absolutely. What's the good way there? It's going to be the pruritus. Severe pruritus. It's going to give it, and then also running with an autoimmune disease. So E is your correct answer. Now we know that this is from too much copper, right? So we can pretty much eliminate all the things that relate to iron as far as hepcidin, ferritin, and elevated total iron binding capacity. So are we C or are we E? Or C. So remember E, it's actually an increase in urine copper excretion. Good job, Wilson's disease. Wilson! So the key with this is that the radiologic study is showing alternating areas of stenosis dilatation throughout the bile duct system. I'm just going to put that in the realm of, we talked about intrahepatic, and extrahepatic, so we've got to go with D. I'm going to go with D. All right, that's all I have for you.